Welcome back to the deep dive. Today, we are shifting our focus a bit. We're moving from the world around us to the world inside us.
Say inside.
Yeah, we're turning the lens inward, quite literally, to look at a detective story that is happening right now, often completely in the dark, inside the human stomach.
It's absolutely a detective story.
Yeah.
And, like any good mystery, the most important clues are often the ones you aren't even looking for.
Right.
They're hidden in plain sight, or maybe more accurately, just beneath the surface of the stomach lining.
Exactly. We're talking about gastric polyps. Now, I can almost hear the listener's internal monologue already. Polyps.
Yeah.
That sounds dry. That sounds like a terrifying medical textbook.
I get it. Yeah.
But stay with us. We've come through this really comprehensive text called Clinical Management of Gastric Polyps and Subepithelial Lesions. And when you actually dig into this source material, it's not just about dry medical definitions. It's a high-stakes game of hide and seek.
The stakes are incredibly high because the stomach is just a master of disguise. And the mission, I guess, for this deep dive is to decode that disguise.
Okay.
We want to help you figure out which of these bumps are just harmless bystanders hanging out in the stomach lining and which ones are the villains, the actual precursors to cancer.
And here's the hook that grabbed me immediately, and I want to check my understanding on this because it seems wild. Over 90% of these gastric polyps are found accidentally.
That's correct. Over 90%. They're what we call incidental findings.
That's a staggering number. I mean, that means the vast majority of people walking around with these growths have zero idea they're even there.
None at all.
You go in for, I don't know, heartburn, or maybe you swallowed a coin, or you're just doing a routine check, and boom, there's a growth.
Precisely. For the vast, vast majority of patients, these polyps are silent. They aren't causing pain. They aren't causing nausea. They are just there. But, and this is the crucial context we need to establish right at the top, silent does not mean innocent.
And that's the central tension of this whole discussion, isn't it? They don't hurt. Why do we care?
We care because of potential. Some of these silent bumps are, ticking time bombs. Others are basically just skin tags of the stomach. And the doctor's job, and what we're going to explore today, is that risk stratification. How do we separate the noise from the signal using these high-tech cameras and pathology reports?
Okay, before we get into the nitty-gritty of the usual suspects, let's set the stage a bit visually. I think this helps with the experience. Imagine you're a gastroenterologist. You're guiding an endoscope, which is basically a high-tech snake with a flashlight and a camera down the esophagus and into the stomach.
It's a really unique environment. It's dark, obviously. The walls are pink. They're glistening, covered in this protective mucus. And it's not a smooth balloon. It's got all these folds and valleys. It's called rugae. It's a very dynamic landscape.
And then suddenly on this almost alien landscape, you see a mound, a bump.
That's the polyp, an abnormal growth of tissue projecting from that mucous membrane. And in that split second, the doctor has to make a series of really rapid assessments. Is it red? Is it pale? Is it flat? Does it have a stalk like a little mushroom? All these things matter.
So we mentioned the silent majority, but let's talk about the noisy exceptions. Because sometimes these things do make themselves known, even without a camera. When do they stop being silent?
They stop being silent when they interfere with the mechanics of the stomach or when they start to break down. The most common sign that something is actively wrong with a polyp is gastrointestinal bleeding.
Bleeding inside the stomach. That sounds dramatic, like a scene from a horror movie.
It can be, but, often it's much more insidious than that. It's slow. It presents as anemia.
Anemia?
Yeah, and this is a key insight for you listening. If you have unexplained anemia, low iron, fatigue, you're looking pale, and your doctor can't find a dietary reason, they have to look at the stomach. A polyp might be slowly, silently oozing blood every single day.
So the tiredness is the clue. It's the check engine light.
Exactly. It's a metabolic clue. But you're right. There are cases where it isn't subtle at all. The source material highlights these really dramatic case reports of large inflammatory fibroid polyps.
Okay.
These aren't just oozing. They can hemorrhage. There are reports of patients going into shock because of the rapid blood loss.
That's terrifying. And I saw something in the source about obstruction, too. Like the polyp can physically block the exit?
Yeah. Think about the plumbing of the stomach. It has an exit valve called the pylori, which leads to the small intestine. If a polyp grows right next to that exit and it's on a stalk, it can act like a ball valve.
A ball valve? What do you mean?
I mean, you can literally swap into the opening and plug it up. This causes something called gastric outlet obstruction.
And what does that feel like?
Oh, it's a medical emergency. You get severe abdominal pain, projectile vomiting. It's a very serious situation.
Okay, so those are the extremes, hemorrhage and blockage. But what about the vague stuff? Because I feel like everyone has stomach issues now and then. How do you distinguish I ate too much pizza from I have a polyp?
That's the challenge, right? The
Yeah.
symptoms are often very nonspecific. Patients report acid reflux, dyspepsia, which is just the medical term for indigestion.
You're right, I was going to ask.
Yeah, just that general upset stomach feeling, or even chest pain. But there's one symptom that is a very specific flag: early satiety.
Early satiety, let's unpack that.
It means feeling full way too fast. You sit down to eat a burger, you take 2 bites, and you feel like you've just eaten a Thanksgiving dinner.
Wow.
You're physically unable to finish a normal-sized meal.
And why is that? Is it because something has just taken up space in there?
Exactly.
I
Or
see.
the stomach wall has become rigid and it just can't stretch the way it's supposed to.
Yeah.
That is a sign you should never, ever ignore.
And there was one other specific symptom set mentioned for a rarer type, neuroendocrine polyps. This sounded almost systemic.
Right. These are distinct. They aren't just mechanical lumps. They can be secretory. They can mess with your hormones.
So it's not just a stomach problem.
No, it becomes a whole body problem. Patients might experience nausea, vomiting, significant weight loss, and diarrhea. It's a whole body reaction, not just a localized stomachache.
So we have the symptoms, we have the visual of the camera going in. Now let's meet the characters in this story. The source material categorizes these bumps into specific types. Let's call them the usual suspects.
Yeah, and if we're playing the odds, there are 2 main types that doctors see constantly.
And the first one is the fundic gland polyp. And here is where I think we have a massive aha moment for the audience. There's a direct connection here to a medication that millions of people take every single morning.
The pill connection, yes. There is a very strong, well-documented association between fundic gland polyps and the chronic use of proton pump inhibitors, or PPIs.
These are the drugs for heartburn. Omeprazole, pantoprazole, the purple pill.
Correct. And I want to be careful here because PPIs are wonder drugs in many ways. They prevent ulcers, they can stop esophageal cancer from reflux disease, but, biology is all about trade-offs.
What's the trade-off here? How does stopping acid create a bump?
It's a fascinating feedback loop. When you take a PPI, you suppress the acid-making pumps in the stomach.
Right.
The stomach senses this lack of acid and thinks, hey, I need to work harder. So it releases a hormone called gastrin to tell the stomach lining to grow and make more acid.
So the drug pushes the acid down, and the body's response is to push the growth button to try and compensate.
Exactly. That's a perfect way to put it. It's a feedback loop. And that chronic stimulation causes the parietal cells, the acid-making cells, to get clogged up and form these little cystic dilations, and those are the fundic gland polyps.
So it's a side effect of the stomach trying to do its job against the medication.
In a way, yes. It's a structural change in response to a new chemical environment. Now, the good news, and this is vital, is that these are usually benign. Yes. In the general population, the cancer risk for these specific PPI-induced polyps is incredibly low.
Okay, that word usually always carries a heavy load in medicine.
It does, because there is a genetic exception we have to look out for, and that's FAP, familial adenomatous polyposis.
FAP.
It's a genetic condition where people grow hundreds, sometimes thousands, of polyps in their colon and stomach. It's very serious.
So if a doctor sees these bumps, how do they know if it's just the heartburn meds or this serious genetic condition?
It's all about context. If you're 50 years old and you've been on omeprazole for 10 years, it's almost certainly the meds. If you're 25 and you have a carpet of polyps throughout your stomach and colon, we worry about FAP.
And if it is just the meds, what's the fix? Do you have to cut them out?
Usually no. The advice is often to simply stop the medication, if possible. If you stop the PPIs, the polyps often regress. They just shrink away.
That is fascinating. So it's a completely reversible side effect.
In many cases, yes.
But the text did mention a size limit.
Yes. If they're large, specifically larger than 1 centimeter, the guideline is to resect them or cut them out.
Just to be safe.
Just to be safe. We want to get a sample and rule out dysplasia, which is that disorganized cell growth that can happen before cancer.
Okay, so that's the fundic gland polyp. Relative to the others, he's sort of the nice guy of the group. Mostly harmless, often caused by meds.
Generally speaking, yes.
Now let's meet the troublemaker, the hyperplastic polyp.
This one is a different beast entirely. If fundic polyps are often caused by medication, Hyperplastic polyps are often caused by a bacteria,
A bacteria.
specifically Helicobacter pylori, or H. pylori.
I've heard of this. This is the bacteria that was discovered to be the cause of ulcers, right? The one that won the Nobel Prize.
That's the one. H. pylori is a major driver of inflammation, and hyperplastic polyps are essentially a reaction to chronic injury. The stomach lining is inflamed, it's irritated, usually by this bacteria, and it throws up this chaotic, exaggerated regenerative tissue to try and heal itself.
So it's like a scar that didn't know when to stop growing.
That's a great analogy. It's overexuberant healing. And the description of these in the text is really vivid. They are described as vascular.
Which means they're full of blood vessels.
Right. They're red, they look angry, and because they're so full of blood vessels, they bleed easily from surface erosions. Remember, we talked about anemia earlier. These are the top suspect. If you find a hyperplastic polyp, you've likely found the source of the bleeding.
And unlike the fundic ones, these have a real bad side. It's not just about bleeding.
No. They have malignant potential. Dysplasia, again, that pre-cancer step, or even focal cancer, is found in anywhere from 5 to 19% of these polyps.
Up to 19%. Wow, that's nearly 1 in 5. That is statistically significant.
It is not something to ignore. And size is the biggest risk factor. If it's bigger than 1 centimeter, or if it's what we call pedunculated,
Meaning it's hanging on a stalk.
exactly, like a little cherry on a stem, the risk is higher.
So what's the game plan for these angry red bacterial polyps?
It's a two-pronged attack. First, you cut them out if they're larger than half a centimeter.
Okay.
But, and this is the key insight for our deep dive, just cutting them out isn't enough. Remember, they are caused by the environment, the soil of the stomach.
If you cut the weed but you leave the fertilizer.
Exactly. If you don't treat the H. pylori infection, the polyps will just grow back. You have to weed the garden, A&D, treat the soil. You must eradicate the bacteria with antibiotics. The recurrence rate is very high if you don't.
That makes perfect sense. So we've got the medication side effect in the fundic polyps, the bacterial reaction in the hyperplastic polyps. Now we move to section 3 of our outline, the dangerous and the deep. These sound like a suspense movie title.
It does, but it's pretty accurate. First, let's talk about the dangerous. We're talking about gastric adenomas.
Adenomas. Now, most people know this word from colonoscopies. They found an adenoma, they took it out.
Yes. And in the stomach, they are just as concerning, if not more so. These are true precursors to gastric adenocarcinoma stomach cancer. These aren't just reactive bumps like the hyperplastic ones. These are neoplastic. The cells themselves have mutated.
So this is the first step on the road to cancer.
It is a major, major step.
So if a doctor sees an adenoma, is there any wait and see? Any watching it?
Absolutely not. The strict protocol from the ASGE, the American Society for Gastrointestinal Endoscopy, is to remove all gastric adenomas. No exceptions. The cancer risk is simply too high to leave them in place.
And the source mentioned that even after you remove them, you're not out of the woods?
No, you're not. They have a recurrence rate of about 2.6%. But more worryingly, gastric cancer is diagnosed in 1.3% of people who have had one removed, even after removal.
That sounds low, but I'm guessing it's not.
It's a huge red flag. It means the entire stomach lining, the soil, is unstable. These patients need very close surveillance for the rest of their lives.
We'll get to the surveillance schedules later, the when do I come back part. But I want to touch on the deep. We've talked about things growing on the surface, but what about things growing beneath the surface?
This is where it gets really tricky. We call these subepithelial lesions. Think of the stomach wall like the wall of your house. Most polyps are like pictures hanging on the wallpaper. These lesions are in the dry wall, or the studs behind it.
The iceberg concept. You only see a smooth bump on the surface, but the real mass is underneath.
Exactly. And because they're deep, a normal camera can't see what they're made of. You can't just pinch them off with forceps.
Why not?
Because you might perforate the stomach wall, literally punch a hole right through the organ.
That sounds like a complete disaster. So how do they figure out what they are if they can't biopsy them easily?
They use a special tool, something called EOS endoscopic ultrasound.
Combining a camera with sonar.
Yes. It's an endoscope with a tiny ultrasound probe on the tip. It allows the doctor to see through the layers of the stomach wall. They can measure the mass, see exactly which layer of the wall it's coming from, and decide if it's risky.
And the big name here, the one to worry about, is GIST, right?
The GIST, gastrointestinal stromal tumors. These are serious. They can be malignant, and they can also be found on CT scans, sometimes incidentally.
And there was a specific drug mentioned for these, imatinib.
Yes. This is a great example of precision medicine. Yeasts often have a specific genetic mutation, the KIT mutation, and imatinib is a targeted therapy that inhibits that specific mutation pathway.
So it's not just cut it out, it's analyze the genetics and attack it chemically.
Precisely. It really changed the landscape for treating these tumors. Although I should add, if a yeast is larger than 2 centimeters, the recommendation is still resection. You want it out of there.
Okay, moving on to section 4. This is the part that really blew my mind. The body is connected. We tend to think of the stomach as this isolated bag of acid, but the source material highlights these genetic syndromes where the outside of the body gives clues to what's happening inside.
It's fascinating, isn't it? It completely challenges the siloed way we often view medicine. The skin can literally be a window to the gut.
Let's start with Poitsdager syndrome. What are the external signs for that?
Lip hyperpigmentation, dark spots, almost like freckles or moles, on the lips or inside the mucous membranes of the mouth.
So you see spots on someone's lips, and that tells you.
It tells you they might have a certain kind of polyp called hematomatous polyps in their stomach and intestines that have a very high risk of turning into cancer
How high are we talking?
by age 30 on average.
Age 30, that is incredibly young for gastric cancer.
It's a very aggressive syndrome.
Wow. So a dermatologist noticing spots on the lips could literally save a life by referring someone to a gastroenterologist.
Absolutely. The signs are there if you just know how to read them. Then there's Cowden syndrome,
And what are the clues there? What am I looking for?
facial trichomoniasis. These are small, flesh-colored bumps on the face, usually around the nose and mouth. Also something called achorokeratosis, rough spots on the hands or feet.
And if you have those bumps on your face,
You're at a much higher risk for malignancies in the breast, the thyroid, and the genitourinary tract, in addition to having stomach polyps. It's a multi-system genetic disorder.
it's terrifying, but also kind of empowering to know that these visible signs exist. And then there was juvenile polyposis.
Yes, and don't let the name fool you. It doesn't just affect children. Juvenile refers to the type of polyp tissue, not the age of the patient. It affects adults, too.
And the risk,
It carries a 50% lifetime risk of gastric malignancy.
50%, that's a coin toss.
It is severe. In neonates, in newborns, it can even cause brain and heart anomalies. But for the adult patient, it means very rigorous lifelong surveillance.
This brings us perfectly to section 5, the detective work. We know the suspects, we know the signs, but how do doctors actually gather the evidence? It turns out they don't just go in and start snipping randomly.
No, absolutely not. It has to be systematic. You can't just fly blind in there. The source details the Sydney System.
The Sydney System. Sounds like a heist plan. What is it?
It's a global biopsy protocol. It's essentially a map. Because here's the thing. Some of the biggest risks, like atrophy, which is thinning of the lining, or intestinal metaplasia, which are precancerous changes, can be completely invisible to the naked eye.
So you can't just look at the pink tissue and say, looks good.
Right. The tissue might look totally normal, but be microscopically dangerous. So the Sydney System mandates taking biopsies from specific standardized locations, the antrum at the bottom, the incisura on the angle, the lesser curvature, and the greater curvature.
It's like testing the soil in different corners of the garden to get the full picture, because the weeds might not have sprouted yet.
That is a perfect analogy. You're mapping the terrain to risk stratify the patient. If you find metaplasia in the antrum in the body of the stomach, for example, the cancer risk is much higher than if it's just in one spot. This mapping tells you how aggressive you need to be with follow-up.
Now, for the visible polyps, there was this really cool trick mentioned in the research, the vinegar trick, acetowhitening.
This is really clever. It was highlighted in a study by Lafoy and colleagues. It's low-tech chemistry meeting high-tech imaging.
So how does it work?
The doctor literally sprays acetic acid, which is essentially concentrated vinegar, onto the polyp during the endoscopy. Then they use a dual-focus camera to zoom way in.
And what happens? What do they see?
The acid reacts with the proteins in the cells. It causes a color change, a whitening reaction. But here's the key. Malignant parts of a polyp, the cancerous parts, have different protein structures. They lose that white color much faster than the benign hyperplastic parts.
No way. So you can watch the color fade in real time to see where the bad cells are?
Yes. It helps doctors identify malignancy within a polyp live during the procedure.
Why is that so important? I mean, why not just cut the whole thing out anyway?
Because sometimes patients have massive spreading polyps, or they might have dozens of them. You don't want to perform a huge, risky resection if you don't have to. This technique helps target the most dangerous spots and avoid indiscriminate cutting. It preserves the stomach while targeting the cancer.
That is incredibly smart medicine. And again, we come back to the background or the soil. The source really, really emphasized this. It's not just about the polyp, it's about the tissues surrounding it.
This is critical. I can't stress this enough. If you remove a polyp, but you ignore the background gastritis, you have failed the patient. You must biopsy the background tissue to check for that H. pylori bacteria we mentioned earlier.
I want to hit this stat hard because it shocked me. H. pylori is associated with up to 89% of non-cardia gastric cancers globally.
89%. It is the primary risk factor. The World Health Organization classifies it as a Class 1 carcinogen, right up there with cigarette smoke.
That is a staggering, staggering number. But there is a hopeful stat in there too, right?
Yes, and this is the point that is so important. Eradicating the bacteria, just taking a course of antibiotics, reduces the cancer risk by roughly 32%.
That's massive. That's a third of the risk gone just by taking pills.
It just underlines why the detective work isn't just about finding the lump. It's about finding the cause of the lump.
So we found the polyp, we've mapped the stomach, we've tested for bacteria. Now, section 6, taking action. What's in the toolkit for getting these things out?
It really depends on the size and the type. It's a ladder of escalation.
Okay, start at the bottom row, small polyp.
For small stuff, we use forceps. Basically, tiny little tweezers pass through the scope. You can just pinch it off. It's called cold forceps polypectomy.
Okay, step up, a medium-sized polyp.
For slightly bigger ones, we use snares.
A snare is like a little lasso.
Exactly. It's a wire loop. You lasso the polyp at its base and tighten it. You can use a cold snare, which is just mechanical cutting, or a hot snare, which uses electricity to burn through the base and cauterize at the same time.
Hot snare sounds more thorough.
It stops bleeding better, but it also carries a risk of burning too deep into the stomach wall. So for smaller ones, cold snare is actually preferred now. It's safer.
And for the big monsters?
Yep.
Or the flat ones that are stuck on there like a sticker?
There we move to the advanced techniques. EMR, which is endoscopic mucosal resection, and ESD, endoscopic submucosal dissection.
These sound like surgery.
They are surgery, but performed entirely from the inside through the endoscope. With EMR, you inject a fluid cushion under the polyp to lift it up like a blister. Then you can lasso it more easily.
And ESD?
With ESD, the doctor uses a tiny electric knife to meticulously peel the lesion off the muscle layer. It allows them to remove large, flat tumors in one single piece, which is better for pathology.
That sounds incredibly difficult.
It requires a very high level of skill. But it can save a patient from having to have part of their stomach removed surgically, which is a massive operation.
Amazing. Now, we touched on neuroendocrine tumors earlier. The treatment there seems a bit more complex.
It is. It depends on the type. Type I and type 2 are usually associated with that lack of stomach acid we talked about earlier. They're less aggressive and can often be managed endoscopically. You remove the bigger ones and watch the small ones.
And type 3?
Type 3 is different. It's sporadic. It's not related to acid levels. It's much more aggressive. That often requires actual surgical resection.
As in cutting into the stomach from the outside?
Yes, because they have a much higher risk of spreading to the lymph nodes.
Okay, so the polyp is out. The patient wakes up. Are they done? Can they forget about it?
Never. This is a chronic management issue. The checkup schedule, or surveillance, is absolutely vital.
So it's not one and done?
Not at all. Let's look at the schedule. If you had a hyperplastic polyp, the bacterial one, and no cancer was found, you come back in 1 year for another look.
But if you treated the bacteria, does that change things?
Even then. In fact, you should come back in 3 to 6 months to prove the bacteria is actually gone and to see if the polyp has shrunk or disappeared. You get confirmation that the treatment worked.
What about the adenomas, the precancerous ones?
Strictly 1 year after removal. If that scope is clear, then you can stretch it to every 3 to 5 years. But you never really stop watching an adenoma patient. Their stomach has proven that it wants to make bad cells.
And pernicious anemia? We haven't fully defined that yet?
Right. Pernicious anemia is an autoimmune condition where the body's own immune system attacks the stomach lining, leading to a B12 deficiency. It destroys those acid-producing parietal cells.
So these patients have a much higher cancer risk.
A 2 to 3-fold increased risk. So they need regular scopes, too, every 3 years if they have extensive damage or atrophy to the stomach lining.
And finally, the FAP patients, the genetic condition.
Yearly. The risk is just too high to wait any longer than that.
It sounds exhausting for the patient, but I guess the alternative is missing a cancer until it's too late.
Exactly. Surveillance is prevention. Gastric cancer is often silent until it's very advanced. These scopes catch it when it's still just a polyp, when it's curable.
So, what does this all mean? We've gone from this mysterious bump in the dark to high-tech removal and a lifetime schedule of checkups.
I think the summary is that gastric polyps are clues. While most are quiet and harmless, they are signaling something about the body's overall health.
They really are the check engine light.
Yes,
Yeah.
they might be signaling a genetic issue you didn't know you had, a bacterial infection like H. pylori, which is damaging the soil, or even just a side effect of your daily heartburn medication.
And that transition from just a polyp to cancer isn't inevitable.
That is the key takeaway from all of this. It is preventable. With the right detection, using those biopsy maps, and the right management eradicating bacteria or removing the polyp completely, we can interrupt that journey. We can stop the villain before it ever gets a chance to strike.
That is a powerful thought. And I want to leave our listeners with one last thing to mull over. We talked about the skin-stomach connection.
Right. Peutz-Jeghers and Cowden syndrome.
Exactly.
Yeah.
It challenges the way we think about our bodies. We go to a dermatologist for our skin, a gastroenterologist for our stomach, a dentist for our teeth. We treat them as separate departments in a big company. But this deep dive showed us that a spot on your lip can predict a tumor in your stomach.
The body is a unified system. It really doesn't care about our medical specialties.
It really doesn't. So next time you look in the mirror, remember, the outside is telling you a story about the inside. You just have to know how to read the clues.
Well said.
That's it for this deep dive into the hidden world of gastric polyps. Thanks for listening, and stay curious.
And stay healthy.